Motorized spiral enteroscopy, a novel device-assisted enteroscopy. Small bowel examination is often challenging due to the long length of the small bowel. Common indications for deep enteroscopy include management of GI bleeding of obscure origin, small bowel polyp and tumors, uncomplicated GI tract stenosis for biopsy or dilation, removal of small bowel foreign body, or performance of ERCP in altered anatomy. Before the introduction of motorized spiral enteroscopy, the device-assisted enteroscopy systems include the long-type double-ballooned or single-balloon enteroscopy systems, and also the manual spiral enteroscopy system. There are also the short-type double-balloon and also the short-type single-balloon systems for ERCP in patients with altered anatomy. In the balloon overtube assisted enteroscopy systems, the push and pull technique is used for pleating of the small bowel onto the overtube for scope advancement. In the manual spiral overtube enteroscopy system, the spiral overtube is rotated manually in order to pleat the small bowel onto the overtube for scope advancement. Both the balloon-assisted enteroscopy systems and the manual spiral enteroscopy system have its own strengths and weaknesses. In the double balloon system, while it is often characterized by a deeper depth of scope insertion, leading to a relatively higher total enteroscopy rate, up to about 44% by the combined approach or integrate-only approach, this often involves a long procedure time. On the other hand, in the manual spiral enteroscopy procedure, while the shorter procedure time can often be observed, the maximal depth of scope insertion by the retrograde approach is often quite limited, leading to a disappointingly low total enteroscopy rate. Given the limitations of the currently available technologies of deep enteroscopy, the motorized spiral enteroscopy system is designed in hope to achieve a deep insertion depth plus a high total enteroscopy rate at a relatively shorter procedure time. In the new motorized spiral enteroscopy system, a motor is mounted on the handle of the power spiral enteroscope. This is controlled by a foot switch connected to the control unit in the system. A force gauge is included to allow visualization of the degree of resistance encountered on the spiral overtube rotation during the procedure. The spiral overtube is a single-use device, and during the procedure, a special lubricant called the endolan is used. When we perform antegrade procedures, a dedicated mouthpiece, which is larger than the usual mouthpiece used in upper endoscopy, is used to allow passage of the spiral overtube. The motorized spiral enteroscope has a working length of about 1.7 meter and comes with a 3.2 millimeter channel and a water jet function. The length of the spiral overtube is 24 centimeters. The first human case of antegrade motorized spiral enteroscopy was performed by Professor Horst Neuhaus from Germany in 2016. This is an antegrade procedure performed under general anesthesia. The indication for the procedure is angiodysplasia detected by small bowel capsule endoscopy. The maximal depth of insertion was 250 cm distal to the ligament of Treitz, and the time to maximal depth of insertion was only 20 minutes, and APC was successfully applied to the angiodysplasia. There was no mucosal injury related to the spiral overtube. Now let's take a look at how we performed overtube assembly and system testing before we perform the motorized spiral enteroscopy procedure. Today we are going to perform a motorized spiral enteroscopy procedure. Before we start, we need to put the equipment together and perform the necessary testing recommended by the company. So now we are putting the overtube onto the scope. So you can hear the snap here, and now we'll completely lock the system so it's fully attached. Next, we are going to test for the backward rotation. I'm going to step on the pedal, we'll test it in a straight configuration first, and then we'll bend the scope and test it in a bent position, and then we'll test the safety feature. So if there's encountering of high resistance during the rotation of the overtube, the system will stop the rotation. Now we are ready to test the forward rotation. We're going to test it in a bend position, and then we will test the safety feature. So now we have completed testing, and the scope is ready for use. When we perform scope intubation in an antegrade procedure, the patient's neck should be extended to ease passage through the pharynx, upper esophageal sphincter, and cervical esophagus. Then, slow forward rotation is engaged using the foot switch as the upper sphincter is entered. Fluoroscopy is helpful in allowing the endoscopist to see the scope position and scope configuration during procedure. In antegrade procedures, it is important for us to allow the complete clearance of the spiral overtube from the lower esophageal sphincter before allowing the overtube to engage the pyloric sphincter. Engagement of the pyloric sphincter and the lower esophageal sphincter at the same time will prevent proper rotation of the spiral overtube, leading to excessive rotation of the engaged part of the GI tract, causing injury. In patients with normal anatomy, the scope advancement could be quite efficient and smooth, leading to a shorter procedure time when compared to balloon-assisted enteroscopy. Occasionally, if acute angulation is encountered, abdominal massage can be gently applied to the abdomen to aid the scope advancement. In this fluoroscopic image, the scope configuration after achieving total enteroscopy is shown. Once a target lesion is reached or the maximal depth of scope insertion is reached, the scope could be withdrawn by activating the backward rotation on the foot switch. It is also important to note that where the scope location is when the scope is about to engage the lower esophageal sphincter of the esophagus. In this fluoroscopic image, it is important to not engaging both the pyloric sphincter and the lower esophageal sphincter at the same time to avoid injury due to excessive rotation of the engaged GI tract. In this fluoroscopic image, when the scope and the spiral overtube is in the stomach, we will continue activating the backward rotation on the foot switch while slowly push in the scope to avoid letting the proximal end of the spiral overtube to engage the lower esophageal sphincter. With this maneuver, the scope itself will be slowly moved out of the duodenum and pyloric sphincter so that it will disengage from the pyloric sphincter before we will engage the esophagus. When we performed retrograde MSE procedure, the ileocecal valve can be intubated with the tip of the enteroscope in the same fashion as during a colonoscopy. If there's problem, we can use manual abdominal compression as needed with activation of the forward rotation on the foot switch to allow the spiral segment to be engaged and advance across the valve into the terminal ileum. Important contraindications to the motorized spiral enteroscopy in this slide here, and the main conditions include perforated ulcer, esophageal gastric varices, GI tract stenosis, patients who are unable to accept the mouthpiece, or the presence of severe active inflammation of the GI tract. We should also be careful when we perform procedures in patients with known structuring disease such as Crohn's disease or radiation enteritis, patients who are pregnant, or there are any prior abdominal or pelvic surgery, including altered anatomy, any history of radiation enteritis, history of dysphagia or swallowing problem, or the mild to moderate inflammation of the colon. We're going to share two video cases here. This is an antegrade MSE for treatment of angiodysplasia in a patient with HHT and recurrent GI bleeding from the small bowel. Now we already advanced the scope into the small bowel, and we're going to see various sizes of angiodysplasias in different parts of the small bowel. Well, we just saw one there, and along the way we're going to see smaller ones, such as this one here. Now with the spiral overtube, we can achieve quite a stable scope position to allow good examination of the mucosa here. Given the known HHT condition, we anticipate we're going to see multiple angiodysplasias, and we're going to ablate as many as we can, but probably targeting the larger ones first. Here, we'll start ablating the larger angiodysplasias. And here's another one. The second case is a retrograde MSE for a patient with suspected small bowel lymphoma. So the patient has already received bowel prep similar to what we give for a patient undergoing colonoscopy. Here, we can see that the bowel is quite clean, and we have good visualization. The scope could be efficiently advanced up into the small bowel, and here we're still in the ileum. Now on X-ray, we can see what the scope configuration looks like. So there's gentle advancement of the spiral overtube into the small bowel here. So when we activate the forward rotation, you can see how the bowel can be efficiently pleated over the overtube. Here we are seeing some normal lymphoid follicles here. So now we are more proximal into the small bowel now. And from time to time, we'll need to do a little scope reduction, and also may need to apply abdominal pressure or massage to aid the scope advancement. And now we're about to reach the target area. Now, as you can see, there's a acute angulation here, but once we advance the scope into this area, we start to see some very abnormal mucosa. This abnormal area is further evaluated with MBI, and multiple biopsies were taken for histological diagnosis. In the next few slides, we're going to review some of the current evidence for motorized spiral enteroscopy. In this study of 30 patients, MSE was used for completion of colonoscopy. You can see that there's a very high cecal intubation rate with a relatively short time to cecum. Multiple therapies can be performed with MSE. In this study, there was no severe adverse event, but a few mild adverse events were seen in 6.7% of patients. In the first prospective clinical feasibility study of antegrade MSE, 140 procedures were performed in 132 patients under general anesthesia. The overall diagnostic yield was up to 74.2%, and some form of endotherapies were performed in 68.2% of the procedures. Technical success rate was high, up to 97%, and the median depth of maximal insertion was 450 centimeters. The median insertion time to the depth of maximal insertion was about 25 minutes, and the antegrade pan-enteroscopy to the cecum was achieved in 10.6% of the patients. The overall adverse event rate was about 14.4%, including 3 patients with deep mucosal tears, and all of them were clinically asymptomatic, and 2 major serious adverse events, including 1 delayed perforation and 1 bleeding from Mary-Weiss lesion. In the first prospective clinical feasibility study for total motorized spiral enteroscopy, 30 patients were included. The technical success rate of antegrade MSE and retrograde MSE were both 100%. The overall total enteroscopy rate was 70%, which is very high, including 16.6% from antegrade approach alone and 53.4% with a bidirectional approach. And the median antegrade DMI beyond the ligament of Treitz was 490 centimeters with a median insertion time of 26 minutes. And the median retrograde DMI beyond ileocecal valve was 120 centimeters with a median insertion time of 17 minutes. The overall diagnostic and therapeutic use were both high, and the overall adverse event rate was about 16.7%, and this time there was no serious adverse event encountered. As we become more familiar with the MSE, we start to see reports of using MSE in patients with altered anatomy. And the first case of MSE for ERCP in altered anatomy was reported by Professor Neuhaus's group. The bilioenteric anastomosis could be reached, and the interventions can be successfully performed for this patient. Despite its promising results, more data is needed to define its safety for MSE in patients with altered anatomy. In 2022, a large multi-center prospective study has been published, including more than 200 patients with both normal and altered GI tract anatomy. The primary objective of the study was to evaluate the serious adverse event rate, and the secondary objectives were to evaluate the diagnostic and therapeutic yield, procedure success, procedure time, and insertion depth. In the post-training phase of the study, 21.5% of the patients had previous abdominal surgery and 10% of the patients had surgically altered anatomy. So for the primary endpoint, SAEs occurred in 2.3% of the patients. Total enteroscopy was achieved in about half of the patients undergoing planned total enteroscopy. The anatomical region of interest could be reached in about 87.5% of the patients. Despite the promising results of motorized spiral enteroscopy, the safety profile of this technology is also of clinical interest. Equipment malfunctions such as spiral overtube disconnection has recently been reported. Endoscopists should be familiar with potential equipment malfunction for this new technology. In summary, both balloon overtube assisted enteroscopy and manual spiral enteroscopy have their own strengths and weaknesses in the management of small bowel pathologies. MSE is a promising new technology that may address the limitations of the current deep enteroscopy modalities, including a shorter procedure time, deeper insertion depth, higher total enteroscopy rate, stable scope position for endoscopic interventions, and long-term safety data is also emerging for this new technology.